Namaskar. Welcome in this live interactive teleconference of MBA in Healthcare and Hospital Management program. Today we are going to discuss about the budget impact analysis. As a health professional, you have been trained about the different dimensions of health in your medical schools or in other institutions. But normally as a health professionals, we do not formally trained as a financial aspect. But when you become one of the manager or administrator, you must understand different dynamics of the financial aspect also. And here the role come into the budget impact analysis, because everything is connected at the back end with the financial component. So you also need to be very careful about your decisions and availability of the resources and many other parameters when you are one of the manager or administrator. To discuss this important topic, we have Dr. Anand Krishnan. Welcome you, sir.
Thank you.
Sir is professor in the Center for Community Medicine in All India Institute of Medical Sciences in New Delhi. So, sir, this important topic, I hope this is very useful for the student, and we are looking forward the different aspects of the budget impact analysis for our students.
Thank you, Dr. Biplab, for introducing me and also inviting me to share my insight into budget impact analysis with your students. So, as a part of this session, we would look at what is budget impact analysis, why do we do it, its purpose, how do we do it, how is it different from a cost effectiveness analysis, and what are the key considerations which go into budget impact analysis. We will also take 2 case studies to understand this in a more practical sense. So coming to what is budget impact analysis. Budget impact analysis is a part of what we call as a health technology assessment approach. In other words, if we want to introduce anything into the health system, new thing into the health system, which was not there, we need to evaluate it, and that is called as a health technology assessment. Even though we use the term technology, it does not actually mean any digital technology. Every medicine, every diagnostic test, every public health intervention, a program could be taken as a technology in this context. So basically we are saying decision makers have to take a call whether you should introduce a new intervention into the existing health system. Whether they should do it, what are its implications. Those are the issues that are addressed as a part of health technology assessment. And economic analysis and budget impact analysis is an inherent part of any health technology assessment module. So ultimately, budget impact analysis is aimed at a decision maker, a policy or a program manager, to decide whether he or she should introduce a new intervention into their current mix of interventions. So that is the question that budget impact analysis answers.
I think, sir, keeping in mind of the different spectrum of our students, maybe here it is worth to mention, like new starting in the hospital, maybe particularly one hospital going on, they may want to start like dialysis service. This is the new dimensions. Maybe they want to start like maybe orthopedics department, a new department.
Yeah, this could also be covered as a part of budget impact analysis. Yeah. So largely from my background, because I come from a public health background, I will look at largely public health interventions. But as you rightly said, this can also be a hospital. And I will take those examples maybe when I come to what is the perspective of analysis. So why is economic evaluation and why do we need to do budget impact analysis separately? I will take an example of when you go to buy a car, right? Most of the times we look at two things. Number one, what is its mileage? Which is a measure of efficiency. In other words, for each rupee that I pay for petrol, how much do I get back in terms of mileage? So mileage is a measure of efficiency. We are very particular, especially in the Indian context. We know whenever we go to buy a car, first thing we ask is what is the mileage. However, we also need to know what is the budget, what is the cost of the car, right? We cannot go without knowing the cost of the car. I cannot go for a very efficient car, but the car is worth say 1 crore of rupees. Because my budget is only, let's say, 10 lakhs or 15 lakhs. So obviously we not only need an information on the cost implication, we also need information on efficiency. So while economic evaluations generally answer the question on efficiency, budget impact analysis answers the question on whether I can afford this intervention to be introduced, right? So I will compare this example with, so just a definition before I compare between cost effectiveness and this. So BIA or budget impact analysis is evidence based because we want all decisions of this nature to be evidence based to assess the financial consequences of the adoption of new intervention given the available budget and resources. So it tries to look at, if you introduce this intervention, what is the change in expenditure from the payer perspective, in which case usually we take healthcare system as a payer perspective. If they adopt a new intervention, what changes in the budget will happen if you introduce this new system in your listing. So as I said, BI is essentially a budget and resource planning tool to aid decision makers deciding whether they should introduce, or it could also be, for example, whether we should introduce as a part of insurance system, right? So typically because it is related to budget, the duration of thinking in a BIA is very short, not more than 5 years, because usually health planning or most planning occurs in a 5-year cycle, but it could be less than 5, but very rarely more than 5. Because that's the time. Also, most programs take time to go to scale. They might start with a smaller proportion, and they might cover 10% and might aim that they will cover everything by 100% by 5 years' time. So that is largely the time frame that you would be using. And it predicts the budget impact and the characteristics of population and healthcare system after adoption of new intervention. And again, I will take examples to take you through this. So just looking at what is the difference between a budget impact analysis and cost effective analysis. They are almost always simultaneously done. If you are doing a cost effective analysis, you can easily use the same set of information and do a budget impact analysis. The perspective changes. In a cost effective analysis, we generally advise, though it is not mandatory, you can also take a payer perspective in a cost effective analysis. But a best perspective in cost effective analysis is taken as a societal perspective, because ultimately for everything, society pays the cost. In one way or the other, either through taxes or through direct payment. Whereas in budget impact analysis, it is clearly going to impact a budget of a payer. So only payer's perspective is taken into account. So for example, indirect cost will not be important, or productivity loss is not a part of budget impact analysis, because they are never reflected in the budget of any system. So while CA applies an economic aspect, the budget impact analysis looks at financial aspects of it. So budget impact looks at affordability, cost effectiveness looks at return of investment. What is the value of my intervention? If I invest $1, how much will I get back? That is what cost effectiveness analysis answers. Whereas budget impact looks at affordability, how much money is needed to start this program. So as I said, time horizon for cost effectiveness, we generally take a long time horizon. We take maybe even 10 years, 20 years, lifetime is also taken. Whereas in this, it's a short time horizon, and therefore generally discounting is not necessarily done in budget impact analysis, where it is taken as an inherent part of analysis in cost effectiveness. And largely budget impact analysis looks at both cost and consequences, but does not really measure the consequences in natural units like life years or disability adjusted life years, those kind of a thing. So if you look at this diagram, which explains what we do, the first column that you see is the current environment, where you have not introduced any intervention. What is the total population? How many population have the disease or the condition in which you are going to intervene? It could be diabetes, heart disease, influenza, whatever disease you are interested. How many people have that? So current disease burden without intervention. Target population is who will be likely eligible for your intervention. And then what is the resource utilization? How many people fall ill? How much does it cost? Those all result in finally in a cost of illness. So at baseline with no intervention or current set of intervention, you might be doing diagnosis using test A, and you might want to replace test A with test B, in which case your first column is with test A. So what is happening, who is eligible for that test, what is the resources used in testing, how much disease does it avert, ultimately what is the cost of illness. So that is the first column. Then you start an intervention, and then you start, if your intervention is a preventive intervention, it will change even your sick population. It will change the number of people with the disease. For example, vaccination. If it is more of a diagnostic or therapeutic intervention, it will not change your burden of disease, but it will change your target population depending upon who is your eligible for that test, depending upon its effectiveness, how much disease does it prevent, and therefore how much of cost of treatment does it avert. So we have two things. One is cost of intervention, and the other is, on one hand, which is an addition to the budget, and we have cost averted due to your intervention. That saves you the budget. So if you add these two, then you get the total budget impact. Because by intervention, you are adding your budget by X amount. By an intervention, you are reducing the cost of treatment. Therefore, that is a cost saved. And the difference between the two gives you the total impact on the budget. And that's why we don't take a very long time frame. This also has to happen if you say the intervention will occur after 20 years, then obviously there is no saving of in the current budget cycle. So it will not be reflected in the budget cycle.
Maybe we can put an example like simple improvement of the water supply in a particular area. So total number of patient reported the diarrhea or waterborne disease due to the contaminated water, and the cost of this. And after we do investment of the improvement of the quality of water, the total number of percentage affected by this similar kind of disease like waterborne disease, and how much cost it's.
So you have the cost of the intervention, which is the cost of improving your water sanitation or water quality, whatever way you are doing it. And the total amount of cost saved, which is due to prevented waterborne illnesses. So this difference will tell you what is the budget. But the only point in here to make is that it depends on what are you looking at, improving water quality. It could be a very short-term intervention, or it could be improving your whole water supply system, which then has a very long life, and therefore its returns will be much better. And it's not short time period is not a good time to look at return of investment in this. But if it is adding of let's say an RO system or adding of some smaller system, then it can easily be done.
Maybe particularly for the small community or village.
Yeah, exactly. In a community, say chlorination of well, or adding a RO system within the supply system. So those kind of interventions can be done.
Maybe particularly for some residential welfare, where like 100 or 200.
Absolutely. So once you do the intervention, your sick population there will be a new set of sick population, target population will change, resource utilization will change due to the prevented illness, and your cost of illness will change. So this is typically what is done in a budget impact analysis. And I will take some slightly more details of how to do it. So as you can see, there are 6 steps which are suggested for a budget impact analysis. First is estimating eligible population. Who is eligible for your intervention? If it is a water supply in a community, the entire community is eligible. But if it is, let's say, a new drug or a new prophylactic agent or a new vaccine, then you might be only intended it for, say, pregnant women or for children below 1 year. So not all population will be receiving this intervention. So you have to be clear who is your eligible. Or if it's a drug, you might have its contraindications, you might have its indications. That will define its eligibility. So depending upon your proportion, so you will have to get a sense of what is that number. Out of the total population, how many will be eligible. And then selecting time horizon. As I said, most of the medical intervention have a very short time horizon. They will show an immediate impact. If you give a vaccine, if you give a drug or a diagnostic test, they all are almost immediately. So you can have a very short time horizon. The only time horizon of interest would be how fast can you scale up. If you can cover the whole population in 1 year, or it will take 2 or 3 years to cover. So that is a good time frame horizon to look at, decide the time horizon. Then identify current and future treatment mix. As I said, what is the treatment pattern currently and how will it change if you do it. For example, and I will take this example later on. Let's say we change a diagnostic criteria. Even that is a change in a technology. So you might be, for example, your definition of a disease changes. Let's say we take blood sugar value is changed. Instead of using a cutoff of X, we take cutoff of Y. Then your eligible population changes. and subsequently the treatment might change, and the impact of those treatment on long-term outcomes might change. So those are the things that one has to look at. And then you convert those into resource uses into costs, and as I said, estimate the change and report the change as an annual budget impact. So that is typically how we do a budget impact analysis. Before I go to some examples, let us look at, so first is that you have to have a very good healthcare system. What is your healthcare system? It is entirely publicly funded. Is it a mix of private and public? Because those will have importance in terms of costs of treatment and whether your intervention, coverage of your intervention. If you change a guideline, it's quite possible that private sector may not adopt it. Then that you might only look at the public sector adoption of that guidelines. So those kind of issues we'll have to look at. So you have to understand your healthcare system. Perspective, again, as I said, generally we do as a payer perspective. It could be a hospital or the person who provides services. So largely provider perspective and its implication for who will pay for it. So generally, so hospitals could be one way. Ministry of Health could be another way. State ministries of health could be another example, depending upon who is going to introduce this and who will be paying for that intervention. Then, as I said, use and cost of same using eligible population, current interventions, what proportion will uptake this new intervention. Off-label use of this new intervention. Very often we have an intervention, but lot of the, for example, you introduce a new drug into the community. It can be used for other purposes also. It was not your intention. You are not interested in measuring that. But it is quite possible that antibiotics are a good example. You might intend it for only one infection, but they might get used for a lot of other infections and might change the other aspects also. So you might have to look at those impacts also to your budget. And again, generally we do not take indirect costs, but when we look at condition-related costs, we discuss time horizons, time dependencies, and as I said, discounting is not really done in budget impact analysis unless your time frame is quite long. If it is 1 to 3 years, discounting is not required. And then ultimately uncertainty and scenario analysis. So the question is especially will come, you have a lot of information which is required, like what is going to be the coverage, what is going to be the cost, how big is your eligible population. The question is from where are these information going to come? Do you have data to accurately make these estimations, or you are going to use alternate sources of data, or you are going to use guesstimates? So depending upon how reliable your source of data for these things are, you will have to do sensitivity analysis. Invariably, most economic analysis, therefore, go by some assumptions because they do not have enough data to drive these kind of, what will, for example, if you introduce a change, how many more people will come on treatment? You may not have enough data on that. So you might have to make a guesstimate. So depending upon those kind of variables where we use assumptions, we may want to see how robust is your analysis to those assumptions. If you change those assumptions, because we don't know, it is not based on evidence, what will happen to your results? So those kind of thing is what we do in uncertainty and scenario analysis. And again, I will explain to them you better when I go into some case studies. So again, it's somewhat repeating. First is identify the budget holder, or who is going to pay for your budget for the new introduction of this. Is it a private player? Is it a hospital? Is it a insurance company? So then is it a government? So that is the thing that first is that is the question, because that is the most critical question, because your results of budget impact analysis will be used by these people. So identifying this is your first step. Then consider the features that influence the budget and coverage decision. Who will be covered? What are being covered under the health system? For example, if it is insurance, will this be covered under insurance? Will it not be covered? Who will not be covered? Who will be covered? What part of it will be covered? And what are the access restrictions to reimbursement? So especially if you are looking at from an insurance perspective. And you need to talk to the budget holder. Which costs are to be included? Which part of those going to be budget? So would you like to look at travel expenditures? Would you want to look lost productivity? As I said, traditionally we only use direct medical cost for these things, but this can be included. These are more often included in the cost effectiveness analysis. Then is estimating eligible population. So again, as I said, once you have an introduction of a new intervention, you have to be clearly defining who is eligible for it and whether that is a static one or that keep changing. For example, if size of a population will change because your population of the population, this itself changes. For example, district itself changes because of migration, because of births, deaths, or it could be because this intervention is effective for 2 years. So if you give it in the first year one, in the second year some of them will not be eligible. They might be eligible again in the third year, but some people who got immunized in second year may not be eligible. So depending upon your vaccine's effectiveness, the eligibility will change from year to year. You can make it very simple. If you are just using it as a coverage, for example, I will cover 10% in year 1, I will cover 30% by year 2, 50% by, then it is more or less a static, it's an assumption. But it is quite possible that you might want to use a dynamic approach. A static approach is very easy. You can do a Excel sheet is good enough for doing that. But for a dynamic approach, you might have to do some sort of modeling, and you will use some decision tree modeling subsequently to show how you can model, because it changes the eligibility criteria itself, whether it is chemoprophylaxis or vaccination. And therefore, it is important to differentiate the incident from the prevalent population. What are the new cases, and what are the treatment of a new case may be different from a treatment of a prevalent case. The cost of treatment will be different for them. So you might have to have not only estimate, this is especially true for chronic diseases where the disease has a continuous prevalence. Then you may want to look at a new MI patient versus a patient with an existing ischemic heart disease who does not have MI. Their treatment and their costs will change. So next is again, what is your current intervention mix in the given the total population? For example, if your key question is being answered at a state level, then your total population mix is the population of the state. If it is at a national level, it is at the national level. If it is a hospital level, people coming to your hospital with that condition is your starting point. That is your total population. Target population, as I said, is all those eligible. For example, you are screening for cancers above 30 years, then your eligible population only people above 30 years, not the total population. If you are screening only women for, let's say, breast cancer treatment screening, then it is only women above 30 to 60 years or 69 years, depending upon your age cutoff, is your eligible population. Identify the current intervention. So what is the coverage with breast screening currently? And if you introduce it as a part of national program, how will that coverage change? In which case, how many new cases will be picked up? How many people will need treatment? Remember, especially if it's a screening program, you are likely to pick up more. So this is not necessarily in the short term, it will not save you money. It will actually increase your budget because you are going to pick up more people. You are going to treat them more than the current situation where hardly anybody gets screened, hardly anybody gets treated. Obviously, it is going to improve life expectancy, productivity, everything. But budget impact analysis does not typically take those into account. So in your short term, you have to budget that if I introduce a screening program, my budget will, to manage the patients who are detected by screening, my budget will have to increase by X amount. That is what your budget impact analysis shows. It is not important that every time budget impact analysis has to show that you are saving money. It is just an indication of how much money you should put in your budget if you are planning to introduce this program. And know the effect of the new intervention. So if you launch a screening program or if you launch a vaccination program, how much effective it will be in real life situation, not in a clinical trial mode or in a controlled mode. So you have to look at in a real life situation what will be the effectiveness. So they are offered less than what they are in a very ideal situation. Ultimate effectiveness of any intervention is coverage into actual effectiveness. So if you cover only 10%, and it is 50% effective, actually your effective coverage is only 5% because only 10% people got the intervention and out of them only 50% got effective protection. So ultimate coverage of effectiveness of any intervention is coverage into its effectiveness. Is the new intervention a substitution? For example, are you replacing drug, say amlodipine by telmisartan? for hypertension in your national treatment guidelines. So that is an intervention. So you'll have to look at what is the cost of treatment with amlodipine, how much it's effective in preventing future problems of hypertensive patients, compared to telmisartan, what is the cost of this drug and what is the cost of preventing future incidents of heart attacks or strokes. Combination, or you are avoiding to add amlodipine plus telmisartan. It is expansion, that you are currently not covering these kind of groups of people, and you are adding, in addition to existing, you are adding more treatment under your package of interventions, or it is supportive care. So again, as I said, very often, because data is not available, we end up using assumptions. If you have data from your hospital, from your health system, there is nothing like it. That is the best way that one can do it. But very often, we do not have this data. Insurance companies have usually very good data on cost.
Can you work on some kind of secondary data like earlier example?
Yeah, so as I said, insurance companies usually have very good insisting on data. And today, even National Health Authority of India has introduced, because it is linked to our PMJAY, they have introduced a lot of this costing information which are available on their website, on National Health Resource for these kind of studies. So there is a website one can look up. So these kind of cost of different packages, cost of different interventions are available. See, for example, cost of a vaccine and cost of medicines are available through even commercial mechanisms and compilations which are there. Hospitals often purchase this. You can go through their rate contract lists. The question is again, what is the time horizon? We discussed cycle length, and I will give you some examples subsequently. Let us take each one of them. So cost consideration. So basically there are two kinds of cost we are looking at: cost of implementation of new intervention and the cost of treatment of the consequences of the interventions. So first is, what is the cost of a vaccination program? What is the cost of so those kind of information? Cost of medicine might be available, but that is not enough. Ultimately, there has to be a cost of delivering that intervention to the population. So it is not only cost of your product, but there is also cost of delivery, which may be relatively constant. Cost of delivering a medicine does not depend on the medicine per se, which makes it more or less a constant thing. Cost of delivery of measles vaccine is not going to be very different from cost of delivery of another injectable vaccine, right? So those kind of things are, you can easily, if you have one information, you can easily translate it to another place. So cost of product, which might be there depending upon the newness of the product. If it's a well-established product, its cost will be available. It's a new product, cost may still need to be calibrated. You may not really know the costs. And remember, very often, especially in the national context, if you introduce a new drug in a treatment guideline, it's because of economy of scale, its cost goes down. If producers know that it is now going to be used extensively, they will reduce the cost. We have seen it in almost all vaccines.
Yeah.
Cost
Not
of
only vaccine, even in some kind of HIV like ART programs also, in the tuberculosis programs also.
Absolutely. So cost of medicine is often you should be doing a sensitivity analysis using cost of vaccines, because cost of this intervention of medicine or even a diagnostic test, you know about what used to be the cost of a PCR test and now what is this cost. So they can drastically change. In 5-6 times they can go down. So that is something that is very sensitive to scale. So you need to have healthcare resource utilization of different. So for example, if you are looking at hypertension, you have to know what is cost of treating an MI, what is the cost of treating a stroke, what is the cost of administering with a accelerated hypertension or left ventricular failure, because these are the consequences of not getting treated well. So the cost of these would be there. If there is an insurance package, you can use that as a cost, as a proxy for the cost. Indirect cost, largely we do not use, but some patient-related cost can be included if the perspective is from society, you will use indirect cost. Otherwise, you will not have to use indirect cost. Time horizon, as I said, for BIA, we take a short time horizon, definitely not more than 5 years, but even a shorter time interval will do. Cycle length is related to your intervention. or either to intervention or to your budget cycle. So cycle could be 1 year. If your budget cycle is 1 year, you want to look at your budget quarterly or half yearly, then you could have a cycle. What happens in a half year cycle? Or if your intervention's life is itself only 1 year, then you might go for a 1 year cycle length. For example, if you are doing an annual vaccination, like for influenza, then you might look at, because the cycle cannot be more than 1 year, because every year you have to repeat the vaccination. So the cycle length depends upon that. Time dependent variables are value of the currency or new interventions. As I said, over a period of time, the cost of things might change. Generally, if you are having a very short time frame of 1 to 3 years, value of currency may not change unless it is to be imported. Obviously, then it is dependent on your foreign exchange rate. If it is indigenously made, the cost do not show that much kind of a variation. As I said, discount rate is usually not recommended. While it is done in an economic analysis where the time horizon is longer, in a typical BIA, we do not recommend discount analysis. And then once you have these all thing information, you put it into your budget impact model, where you provide a detailed description of the analysis in a recommended format. What are the assumptions? What are the inputs? How you got the data for those inputs? How you got your data for the costs? And then scenario analysis. I will come to scenario analysis. Again, you can change. One is sensitive analysis we do for cost and other things. Scenario analysis means that you change your eligibility. Okay, I cannot afford to give it to everybody. Can I give it to a smaller section of people? So you look at changing your eligibility. So change your scenario and look at it. So it does not change your assumptions. It changes your eligibility criteria. Whom will I subject to my? So that is what we call as a scenario analysis. And should I change from payer perspective? Should I include indirect costs? Those kind of things are done in a scenario analysis. So then typically you would look at a budget impact analysis like a diagram. Over a 5-year period, what happens to your budget? And you know based on your existing budget, what is the range of budget that you can afford to give. And then you can see whether over a period of 5 years, does it exceed that range or does it stay within that range, which is shown by 2 red lines. As you see, it need not be cost saving, which is what it will be if it is below 0. Above 0 means that you have to budget for more money in your budget. So depending upon your comfort level and availability of funds in the budget, you can see where it crosses your comfort level in the budget. Option is obviously you decide whether you want to do it or you start looking for more budget. Can you find a space for higher budgetary allocation? You ask for more budget or you reallocate within your budget to this activity depending upon how cost effective is this compared to your existing interventions. So we discussed uncertainties, as I said, efficacy of a vaccine, safety of a vaccine, eligibility population, what is the cost, all of these are subject to variations. None of them are absolutely one value. You will have a confidence interval or an uncertainty interval for cost. But if you take cost, it could be median and IQR. So depending upon you'll have to ensure that you are looking at alternative, what will happen if the cost of vaccine changes? What will happen if the effectiveness changes? It drops from 50% to 40% or 90% to 80%. How much will it impact your budget impact analysis? So those are the things that we handle by sensitivity analysis, where we assess the impact of assumptions being made in our model. And when I take the examples, I will show you how it is done. And then you say whether that assumption changes your direction of for example, in a cost-effective analysis, we will say whether that assumption makes it not cost-effective versus cost-effective. Or whether in the budget impact analysis, it moves from cost-saving to you have to add more costs. So it changes your key results of budget impact analysis. Then you have to actually tell the policymakers. Policymakers usually do not like uncertainties. They want very dogmatic answers. But most of these budget impact analysis and economic analysis have inherently an uncertainty, and it is important to communicate that uncertainty to policymakers so that tomorrow it does not come back to bite you. No, you said it will only cost X amount of dollars. No, we are doing it. It is costing me 2 times more. Because then we don't know what, once you implement, we don't know what is going to happen. Our assumptions for base case analysis may not be true. And when you start implementing, it might change. And therefore, it is important to also communicate uncertainty in your budget impact analysis through sensitivity analysis and by tornado diagrams. And again, I will show these using examples subsequently in my case studies. And then as I said, validation of BMI, budget impact model, is ultimately based on experts, and ultimately it's based on how things play out in reality. So I know I told you many of these concepts, but now I will take 2 examples and take you through those budget impact analysis for you to understand these things better. The first one I am taking in a publication which is already there. It is from Colombia, payer's perspective, so government's perspective, who is going to pay for it. And they have a time horizon for 3 years. And I've given the reference. If you are interested, you can go and read it in detail. What they are trying to do is, what happens if at a national guideline we change the cutoff value for hypertension from 140 by 90 to 130 by 80, which is so we start everybody who has 130/80 on treatment rather than wait till BP of 140 or 90. So it is a change in a treatment guideline for a disease. And so we want to treat earlier, right? So our existing scenario is people with 140/90 are put on treatment, but in the new scenario, people above 130/80 are put on treatment. So that
by changing the definition, they increase the number of the eligible people.
Exactly. So and we will see in the next slide how the eligibility has changed. So this is the intervention at national level. As you can see, this can apply for diabetes, for any cutoffs that we use. What happens if you change the cutoff for treating a patient? In the next example, now you should carefully look at both the left side and the right side. The left side is, right side gives you the assumptions that they have taken, which is what will be the proportion of eligible if you have 140 by 90. And what happens if the eligibility changes to 130 by 90? What is the increase? And that is actually translated into numbers in your right side boxes, right? So we have the box starts with the total population. Then it says what will be the eligible population, will be labeled as hypertensive in scenario A, which is 140 by 90, and scenario B, which is by 130/80. And then you start treatment. And since you are treating earlier, you would expect that the long-term consequences of MI, you will prevent more of MIs and more of heart attack, strokes by treating them earlier at a lower level. It is important here for those who do not understand is that blood pressure is actually risk of MI and stroke increases linearly. 140 is a cutoff where we use it, but it does not mean that people at 130 by 80 have no risk of MI or heart attack. The relationship between blood pressure and stroke and MI is actually a linear one, with a slight increase at 140/90, which is why we use it as a cutoff. But it is not zero below it. So if you treat earlier, many of them will be prevented. But at the same time, if you also look at carefully, they have also changed the adherence to treatment. We know that people at 130/80 are less likely to adhere to treatment because they will have no symptoms. Whereas people above 140/90 might have some symptoms like headache, and they are more. So your assumptions will change. You may not have real value, so you will have to put some assumption. How much will the adherence change between 140/90 and 130/80? You may not actually have any data for it. So you may have to assume some assumptions there, and then that should be subject to sensitivity analysis. So you will build, the A is your current model. With this is the treatment, at this cutoff, so many will get treated, so many diseases will be prevented. And if I know the cost of this event, this is the cost of total illness. If I change the guidelines, more people need to be treated, my cost of medicines is going to increase in the budget. But I will prevent more MIs, and therefore cost of treatment of MIs is going to go down. So if you see in the next slide, this is what happens. So they estimated that if in terms of US dollar in a total 3-year cost in a Colombian population, if they were treating 140 by 90 as cutoff, their incurred total expenditure of treatment plus cost was 154,000 odd dollars, US dollars. In the new, it was much less, and therefore it was cost saving. $34,000 would be saved. And if you look at the diagram, the topmost is the total one, but you can see the bulk of this is coming from the second from the top, which is the cost averted due to prevented MIs and strokes. Actual change in the cost of treatment is not very, because the treatment of hypertension is not very costly. By increasing slightly more number of people, your cost of intervention does not change that much. There is a slight improvement, you can see slight increase, but what is cost saving is that you prevent many more MIs and strokes and save money in treating those subjects. And therefore, ultimately, they concluded that changing from 140/90 to 130/80 for treatment is cost saving to the Colombian state government. So that's a budget impact analysis.
I think here something we also need to look beyond this budget impact analysis is long-term effect of the health quality of those people which was saved.
Absolutely. So this budget impact analysis would not look into it.
Yeah.
But a cost-effective analysis would definitely look into it. An averted MI means better quality of life, less dialysis, less burden in this
society.
In societal burden will be reduced. Especially stroke is a highly disabling condition.
Yeah.
So cost-effective analysis will look into those into account. But here it is only taking into account the treatment cost.
Treatment. Yeah.
And this is Dr. Shankar Pinja from PGI Chandigarh works in this area. They have developed national guidelines to conduct BIA, with providing guidelines for how should you be doing it in the Indian context. And after this, I will come to the second case study. So first is because in India, unfortunately, we do not have a single payer. Government of India, we know public health system only caters to a smaller proportion. So what happens if you change and definitely treatment, even if vaccination is introduced by the government of India free, the cost of treatment, lot of it occurs outside in private sector, right? So you have to do a multi-payer perspective. You cannot just do a government perspective in the Indian context, because we have a multi-payer healthcare system. So as we said, first thing is to understand your healthcare system. So if you understand India's healthcare system, it is multi-payer. Therefore, your perspective has to be multi-payer. And they are saying your time horizon should be 1 year to maximum 4 years. And you should state clearly what is your time horizon. Eligibility of estimation, they are expecting top-down approach. In other words, what is your total population, what is the eligible criteria. Like the example that I showed, that was a top-down approach of how many people would be eligible for it. Current mix, again, what is the existing routine care? It could be no care. It could be a current using a treatment X rather than and we replace it by treatment Y. Or it would be treatment X and our revised treatment X plus Y. So depending upon that, you will have to look at both the current mix and the future mix. As I showed in the example, A was current mix, B was future mix. Then how many of this intervention will be utilized? Government might introduce the vaccination, but we know that it is not going to be 100% coverage. Depending upon it might be only 50% coverage. We know new introduction will take some time to mature, will get some time to improve coverage. Even our established vaccinations are still not very well covered. So you might estimate 70%. Again, it depends on what is your mode of delivery. It is how passive it is. Are you going to start a campaign? Then it might be, coverage might be more, but your cost will also be more. Are you going to do a routine service, like you are just saying that we'll make it available at PHC, people have to come and take, then cost will be less, but coverage will also be less. Right? So those kind of issues we'll have to look at. The national guidelines don't recommend discounting. As I said, it is for true. And use very simple cost. Don't go for very complex modeling. Use simple cost, or at the most decision analytic modeling. And I will give you an example of decision analytic modeling in the subsequent one. Again, assessment of cost should include mode of health financing. Who is going to pay, whether it's a supply side or a demand side or a mixed. Who bears the cost of delivering the intervention, and who bears the cost of treatment of consequences. And present year-wise estimates and by the type of budget holder and resource use. In other words, who is the payer? If you are going to use multi-payer, how much will it impact the government? How much will it impact the private sector? Now I am going to use a second case study. This is a study done by us my team. It is under publication. So what we did was that our question was, if we introduce influenza immunization for elderly in India, what will be its budget impact analysis? We use a decision tree approach. In my next slide, I will show what is that decision tree. Our was basically healthcare sector. In other words, the payer would be Government of India. Obviously, the cost of treatment would be both in private and public sector. Study horizon 1 year, because influenza, we currently recommend annual immunization with influenza. So every year it will have to be done. So our study horizon has to be 1 year. Our eligible population is people aged above 60 years. All elderly are eligible for this vaccination. That is our primary scenario 1, base case scenario, what we call as. So our comparison group is no influenza vaccination, because there is currently no influenza vaccination in the country. And what will happen if government introduces an annual influenza vaccination for elderly, single dose, annual intramuscular vaccination of people above 60 of age. And we looked at 2 approaches, like the White said. One is a passive facility-based approach. We will provide it in the PHC, people have to come, or it is a more active field session, like we'll have outreach sessions in the villages along with routine immunization, which is a much more proactive approach. So these are the 2 options within the base case scenario. We also looked at other 2 case scenarios, again, because budget vaccinating only above 65 years rather than people above 60 years. It will reduce the eligible, it will reduce your budget impact. Or immunize only those who have comorbidities. 60 plus, and government's guideline clearly is saying that current guidelines say people with comorbidities should be given, desirable to be given influenza vaccination. So rather than giving to everybody above 60 years, we give it only to people with comorbidities, and the list of comorbidities is there in the government guidelines. And the budget impact analysis was what is the cost of implementation of the program, as I said, cost of vaccine and its delivery, and the cost saved because of influenza vaccination will prevent influenza infections, it will prevent hospitalization, OPD treatment, it will prevent inpatient treatment, it will prevent ICU care. So what is the prevention of cost of all these things? So this is the decision tree model. So it takes you through what will happen if in a population, what is the eligible group, what will happen to vaccination, and if vaccination is effective, how many will be prevented, how many will get affected. If they are affected, whether they will take treatment, or in India, our study found that almost 80% don't go for treatment. They just take treatment at home. About 15% will go to OPD. About 2 to 3% would go to need to get admitted. So all the proportions that you see for disease epidemiology have come from a 4-site cohort study. So it is based on evidence. It is not assumption. How many will go to OPD? How many will need ICU? How many will need inpatient admissions? How many will die? All these are coming from our 4-site study in India based on a large cohort of elderly. 2 things which are, and also we also at the same time estimated the cost of each of these things. We estimated what will be the cost of outpatient treatment. We estimated what will be cost of inpatient with ICU, inpatient without ICU as a part of the study. So both the cost of consequences and the probability of having these consequences come from a real life study. 2 things which we have to assume are which are not part of the study. One is the coverage. What will be the coverage if we introduce? Obviously, it is not available. So we have assumed that with a passive coverage, it will be 30%, and with a more active, it might go up to 50%. And we will use that, we take different values for sensitivity analysis. Vaccine effectiveness is dependent on the review of literature, and general review of literature shows about 50% effectiveness of vaccine in this age group. And it has a 95% CI, which will become part of our sensitivity analysis. The 2 extremes of 95% will be introduced in the sensitivity analysis. So this is how you could use this, and you can say this many people, I will end up with how many people will get admitted, how many people will get OPD treatment, multiplied by cost, you will get your cost of illness. And similarly, depending upon how many people would get vaccinated, we again estimated the cost of vaccination from review of literature. As I said, cost of vaccination is not going to differ whether you are going to immunize an elderly or a pregnant woman or a child. The cost of delivery does not change. It is more or less the same. So we use cost of delivery of other immunization for this delivery, and cost of vaccine is as is currently available in the commercial market. Again, you should, as I said earlier, cost of vaccine will drastically change if it is introduced as a part of a national program. We saw it from hepatitis B vaccine. We saw it in other vaccines. It drastically comes down, maybe 20, 30 times. And this shows you the impact analysis that we saw. On the right, you see what is the cost of vaccination in the third column, both in passive and outreach. As you can see, the outreach is much more costlier because it includes cost of session, cost of... the second column tells you cost of illness of outpatient, inpatient management and ICU. Whereas the third one takes you the cost of illness averted from the baseline. If we did nothing and if we did this, what will happen? And so finally, if you cost of immunization, which is the third column, minus the cost of illness averted, gives you the last column, which is the budget impact. So if I spend this much in the due to vaccination program, this much will be saved in treatment, and whatever is left. So accordingly to this, you can see about 3.8 million or 383 million is what is required, US dollars is required. And we also looked at three scenarios. You can see first row is all above 60 years age, which was our vaccination, which was our base case scenario. Second is all above 65 years of age and all above 60 years with comorbidities. Clearly, you can see that if we say 60 years with comorbidity, our budget impact analysis is the least, right? It only needs 207 million US dollars. So a passive approach, but you are going to prevent less number of outcomes. So our job is to give this. They will decide based on this budget impact analysis which is their preferred approach, which age group they should go, which approach they should attack. So our job is to provide information for decision making, and this provides them that. And if you look at the right side, that is a result of, that's what is called as a tornado diagram, which I referred to earlier. It tells you which variables are most sensitive to your estimations. For example, clearly you can see cost of vaccine is what is most sensitive to this. And as I said, that can drastically come down and all your analysis can completely change if your cost of vaccine comes down. Incidence of influenza, if burden comes down, your cost will go down. And vaccine efficacy. If your vaccine efficacy increases, you prevent more infections and this analysis will change. So what this tells us that these are the three variables which are going to largely impact your budget impact analysis. So I hope with this case study, you have been able to understand and in real life what is the budget impact analysis. So I will summarize by saying that a budget impact analysis is a form of health economic evaluation which is distinct from cost effective analysis because it provides the payer of the decision how much financial consequences of this introduction or removal of an intervention from the current healthcare setting. Just to ensure that it is, you could also remove that I stop doing this, what will happen? And it includes direct and indirect budget impacts, time erosions, issues has to be shorter, health system and financing can impact uptake and hence look at budget impact, quantify budget impact by payer, and characterize uncertainty by looking at what are the important variables which affect your budget impact analysis. Thank you.
Thank you, sir. But before concluding, since most of our students are working in a hospital-based, giving primarily the curative service, can we look into this budget impact analysis like in this scenario? For example, right now current hospital is not providing the, for example, ultrasound service. So he need to calculate the cost if we means hire the purchase the machines, or if we have the cost of the putting the machines and hire the expert, and how much money it is generate over the period of maybe next 3 years, and how much money I have invested, and what is the benefit. So can it also be called as a budget impact analysis?
Typically, in the example that you're going, we are actually not preventing any outcomes, right? It is just a service provision.
Yeah.
Because we are not really looking at whether what happens to the ultrasound patient, whether how many of hospitalization is prevented. Because otherwise, they would have got it done from outside.
Yeah.
So your base case scenario is that they get it done from outside, and your intervention is what happens if you do it, right?
Yeah.
So you can look at budget impact. But ultimately, you will use that impact analysis to fix your charges for the ultrasound.
Yeah.
Right.
Yeah.
At what charge of ultrasound?
How much I am charging?
Will by budget be least impacted? Right.
Yeah.
So that is what will be the question. So slightly different question, but yes. So so you could also look at in terms of in a hospital setting, what happens if I use a different cutoff? If I change my eligibility for say surgery or anesthesia, what happens if this is the current guideline, I change to guideline? How many of hospital stay will be reduced, for example, right? And therefore I will save and patient will save, and whether I can treat more patients because of that. So those kind of analysis can also be done.
Thank you very much, sir. Giving a very complex topic in a very simpler form and giving some of the example, not only from the outside of the country, but from our own country also. So here I would like to say thanks to sir again, and thanks to all the students who are viewing this program, and thanks to the team of EMPC who is helping us to broadcast this program. Thank you very much to all of you.
Thank you.
Namaskar.